This lecture is designed so that with further reading, students will gain an understanding of the role of nurses and midwives in supporting pregnant women and their families. Student midwives will need to address and understand all of these healthcare issues in much greater detail, but this is just a general overview of conception, birth, and care of pregnant women that is relevant for registered nurses and midwives who care for pregnant women in various settings. These include emergency wards, surgical wards, medical wards, and in the community. The learning outcomes for this lecture is so that students can develop a beginning understanding of conception and fertility, some of the stages of prenatal development and early pregnancy issues, understand the importance of antenatal care, education and screening, be alert to common discomforts and danger signs in pregnancy, and have a basic understanding of the labour and birthing process. This material is found in the Hoffnung text in Chapter 3 on the following pages. So, in an ideal world, all pregnancies would be planned. However, this is not the case. Most pregnancies are actually unplanned. Nurses and midwives, therefore, have a responsibility to provide education about reproductive health or to refer people to the appropriate services for assistance, particularly for young people and young families. Before conceiving a child, a mother needs to be in good health, with good nutrition, lots of folic acid, and avoiding adverse lifestyle issues like smoking, drug taking, and alcohol ingestion. The health of the biological father is also important. Smoking in men decreases sperm production and motility, and exposure to some toxic material and chemicals can result in an infant that is small for gestational age. In order for conception to occur, the sperm needs to meet the egg, and this usually happens through sexual intercourse. However, it can also happen by artificial means. The process of fertilization is the uniting of two cells into one. The sperm must swim through the cervical mucosa, through the uterus, and up to the fallopian tubes. Contrary to popular belief, fertilization actually occurs in the fallopian tube and not in the uterus. The ovum or egg, once released by the ovary, travels through the fallopian tube and then is fertilized by the sperm. Timing is all important here. Sperm can live for up to 72 hours in the female reproductive system, but are believed to be at their healthiest only for the first 24 hours. The ovum only remains fertile for the first 12 to 24 hours, providing a brief window for fertilization. The fertilized egg or zygote then travels down the fallopian tube, dividing rapidly, and arrives in the uterus as a mulberry-shaped cell mass. This process usually takes 4 to 5 days, and then implantation occurs into the endometrium. Some women will bleed slightly when this implantation occurs, and this can be often seen as a menstrual period by the mother, meaning that she may not realise that she has actually conceived a child. Male sperm are stronger and swim faster. So the closer the intercourse occurs to the time of ovulation, the more likely that a male child will be conceived. If intercourse occurs earlier, then it will be the female sperm that is still around when ovulation occurs, making it more likely that a female child will be conceived. As an additional activity, you might want to have a look at the issues surrounding infertility. Infertility is defined as the inability to conceive after 1 year of unprotected intercourse. There are many assisted reproductive technology techniques, including donor insemination, GIFT, IVF, and surrogacy, and there are definitions of these techniques on page 84 of the Hoffnung text. This material is not a core part of this module, but midwives may want to research these aspects of infertility in a little bit more detail, so they're presented for your consideration. There are 3 stages of prenatal development. The germinal stage, the first 2 weeks, is what we've been talking about so far. Weeks 3 through to week 8 are called the embryonic stage, and the fetal stage is from 9 weeks to birth. Growth during the embryonic stage and the fetal stage that follows occurs in 2 patterns, and these patterns have some rather challenging terminology associated with them, but we will be coming back to these terms in the future. A cephalocaudal or head-to-tail pattern is the first form of development, and a proximodistal or near to far from the centre of the body outwards is the second pattern. Thus, the head, blood vessels and the heart, the most vital body parts and organs, begin to develop earlier than the arms, legs, hands and feet. At 3 weeks, the head, tail, brain and circulatory system began to develop and the heart has begun beating. You can read more about the embryonic stage, the 3rd through to the 8th week, on page 81 of the textbook. At about 8 weeks of gestation, the embryo develops its first bone cells, and this marks the end of the differentiation into the major structures. At this point, the embryo becomes a fetus, and this occurs at approximately 9 weeks after conception. That's about all we're going to really look at in terms of what happens physically before birth, but we'll now go on to talk about some common terminology within pregnancy and labour, which all nurses should be familiar with. A trimester is the division of pregnancy into 3 parts of several weeks, 13 weeks in each part. Gestation is the length of the pregnancy calculated from the first day of the last menstrual period. And parity refers to the number of pregnancies that have progressed past 20 weeks. This does not reflect whether or not the fetus was alive or stillborn. This slide provides an overview of the stages of prenatal development. You can read more about these stages in your textbook, and you might also want to have a look at perhaps a YouTube video. There's one that has been recommended called the human body. The important thing to understand is that during the first 60 days after conception, this is a period known as organogenesis, which, as the name implies, is when the organs are being developed. It's during this stage that the embryo and the fetus is the most vulnerable to teratogens, which we'll talk about in the next slide. Babies are protected within the watery environment of the uterus by a white, cheesy-like substance known as vernix. A teratogen is any environmental agent that can cause harm to the developing embryo or fetus. Nurses and midwives need to be aware of all of the teratogens so they can advise women who are pregnant that they need to check any prescription medication and make sure that they're not likely to cause harm. They should eliminate any recreational drugs and alcohol. Women need to be cautious of natural remedies because these can also be harmful to a developing fetus. There is no safe level of alcohol consumption in pregnancy. Smoking is not recommended, and women need to be aware that they may passively ingest the harmful substances from secondary and tertiary smoke. Various bacteria, viruses, parasites, sexually transmitted infections, and HIV can also cause harm, and these are all teratogens as well. There are environmental teratogens, and there are physical, biological, chemical, and radiation teratogens. Some recent research has also shown that stress can be a teratogen for a pregnant woman. So it's very important for pregnant women to understand that they need to be relaxed and calm throughout the pregnancies, if at all possible. In some cultures, women are recommended to sing for relaxation, as singing is been found to release endorphins, natural endorphins, which lead to a feeling of well-being and health. This slide shows the critical periods of development for the embryo and fetus. You can see that during the very early weeks, the development of the embryo is particularly vulnerable to disruption if it is exposed to harmful substances. The effects of teratogens are influenced by the timing of the exposure. Disruptions during the first trimester of pregnancy are most likely to result in either spontaneous abortion or serious birth defects. Also, the intensity and duration of exposure is important. For example, the higher the dose of alcohol or cocaine, or the more prolonged the exposure, the greater the chance of harm to the developing embryo or fetus. The number of harmful influences is also important. The greater the number, the higher the chance of risk. The biogenic vulnerability of mother and fetus is also an issue. For example, heavy and prolonged drinking of alcohol is very likely to affect almost all babies. Very moderate drinking may cause considerable harm to one infant, but no measurable harm for another. And this is why the World Health Organization recommends no safe level of alcohol consumption during pregnancy. The thing to remember, which takes us back to one of the earlier slides, is that the woman may not know in the very early stages following conception that she is actually pregnant. And this is when some of the most critical phases of prenatal development occur. This is why, again, it's so important to make sure that women have education about the safety for the fetus prior to conception so that they can make safe choices and make sure they don't inadvertently expose their developing baby to adverse risk factors. As women progress in their pregnancy, it's very important that they don't lie on their back for long periods of time. You can see from this slide that when in the supine position, there is pressure on the descending aorta and inferior vena cava, whereas in the right lateral position, that pressure is relieved. The right lateral position, therefore, is a preferred position during pregnancy, and pregnancy pillows, supports, comfortable bedding, and those sorts of things can make that experience better for the woman. It's vitally important that a pregnant woman has regular antenatal care. Antenatal care allows for the monitoring of fetal and maternal well-being and for appropriate interventions as needed. So a key goal in the initial visit is to build rapport, as this will be the basis for a therapeutic relationship to develop, so that the woman has confidence and trust in the midwives and in the doctors who may be responsible for her care. At each visit, education should be provided that is relevant to the stage of the pregnancy. Antenatal care should include informations about options for birthing, which I will discuss in a subsequent slide. Women also need information about how to stay healthy during their pregnancy, and that includes information about dietary requirements, appropriate exercise, and a review of any medications or vitamins that she is already taking. The importance of prenatal care should be emphasised so that the woman knows that it's important not to miss any visits. Information about teratogens that we've discussed already is important because some women don't understand which substances or environmental hazards can be a problem for them. How to manage common discomforts in pregnancy is also important, and women need to be told about danger or alert signs, such as unexpected sudden bleeding, which are signs that mean that they should present to hospital. There are specialised classes, and it's recommended to include the father or other co-parent in the preparation for parenthood classes to help a woman feel relaxed and confident about birthing her baby in association with the co-parent who's going to be supporting her through that. It's important to link women to appropriate services and support to ensure that they receive the best possible care. Ideally, options for care and childbirth should be something that the woman considers before she gets pregnant or be discussed very early on in the pregnancy so she can make the best choice for her situation. Many women, however, just present to hospital and don't realise until the pregnancy is more advanced. So what options do women have when they are deciding on the birth of their baby? Some of the options are midwifery-led care. This is where a midwife takes responsibility for the pregnant woman and they attend a public hospital, and a midwife will look after them with the medical support that is available. There are also birth centres, home births, and private facilities that can engage in midwifery-led care. There are caseload midwifery programs where the midwife is assigned their own caseload of mothers-to-be, and they monitor them throughout the whole pregnancy and then ideally deliver the baby and follow up in the postnatal period. This is a particularly wonderful form of care during pregnancy because women get continuity of care, as do the co-parents. They get to know the person who is going to deliver their baby, and a therapeutic relationship can be established. Research shows that the outcomes are very good for caseload midwifery and other midwifery care in general. Midwifery care can also be delivered in a birth centre, which is usually located or attached near a local hospital. Some women may choose a private obstetrician, and other women may choose to deliver in a public hospital under the care of public obstetricians. There is still midwifery care, and midwives offer support in a range of settings according to what the woman wants in their childbirth experience. Support from doulas are linked to shorter labours and fewer delivery complications. A doula isn't a midwife, but you can read about the role of doulas. They're quite popular in some cultures, and they're more or less birth assistants. So in our culture, often it is the co-parent or partner of the woman that takes the responsibility for supporting the woman, but as we still have doulas as well, so sometimes people would prefer to have a doula manage their psychosocial aspects of their pregnancy and a midwife the other aspects of their pregnancy, but that's something that you can read about for yourselves. These are some issues to consider when first dealing with someone who is pregnant. It's important to find out whether or not their pregnancy was planned or unplanned, because this may impact on how the woman adjusts to being pregnant and how she feels about it. We also need to find out if this is the first or subsequent pregnancy, as that's part of gaining a full obstetric history. So it's important to know how many times the woman has been pregnant before, any history of miscarriages, the history of each birth, was it a caesarean, a natural birth, forceps, etc. A thorough medical history is needed to explore whether or not there are any issues that need to be addressed. Not all women will disclose an accurate drug and alcohol history, but this is still important to address and to give women education about. It's important to start the mother thinking about infant nutrition. Data suggests that we shouldn't actually lock women into a decision in the prenatal period, particularly first-time mothers, or force them to make any sort of a choice, but give them the information about what's involved and talk to them about the options. Any discussion about infant feeding needs to be very open, and the other aspect of this is getting consent for vitamin K and hepatitis B, because that needs to be given in the birthing unit after the birth of the baby. This is just a very short overview. There are lots more maternal factors to consider, which midwives will focus on in more detail in other units. The age of the mother is taken into consideration. Older mothers have a higher risk of various birth defects, such as Down syndrome, and are more likely to have fertility issues, whereas teenage mothers have an equally high risk of having a low birth weight baby or a stillbirth. So the younger the mother is, or the older the mother is, the more likelihood there is to be complications if there's going to be. It's also important to assess whether the woman is in a safe situation, and if there is any other stresses that she's exposed to. It's a time also to consider issues of family dysfunction and domestic violence. But these are advanced topics which we're not going to go into in this particular lecture. This booklet is a booklet that's given to all pregnant women in New South Wales. It's about food safety, it's about teratogens, and it's about food preparation. So if people have dirty hands, the woman's still going to get ill from consuming any food really, and that is going to have an adverse effect on the fetus. These are some of the danger and alert signs. I'll just leave you to read through these slides in silence. And finally, to conclude this lecture, this is just a little bit of information about the birth process. A full-term pregnancy is considered to be 38 weeks. It may continue to 40 weeks. The usual fetal presentation at birth is a cephalic presentation, in other words, head first. A breech presentation, bottom first or feet first, is a specialist sort of birth which needs often expert intervention, and a transverse presentation may mean that the baby is not facing towards exiting the birth canal and might get stuck. So that's something else that has to be assessed by specialists. There are 3 stages of labour. The first stage is when the cervix is dilating, and this happens from several hours to several minutes. Up to 10 centimetres is the usual cervical dilation, and in the first stage of labour it is the active phase. Towards the end of the first stage, there is a period of transition into the second stage, which is the pushing stage, which culminates in the baby's birth. And the third stage of labour is when the placenta is delivered. So, in conclusion, the role of the registered midwife in helping and assisting the pregnant woman is to obtain a thorough and comprehensive history at the first booking in visit, to determine if the woman is at risk of depression by asking her to undertake an Edinburgh scale, to provide education to women, particularly first-time parents, and to include fathers and other caregivers, and to link to appropriate services and support to ensure that the women receive the best possible care. Thank you.